I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight's show is about polycystic ovarian syndrome and pituitary problems. Two different things, but both involved with hormones and endocrinologists. I have two wonderful guests. It's a pleasure to see you all back. This is Dr. Philip Otterbeck, who is the Chief of Endocrinology at Richmond University Medical Center, and Dr. Lena Lakina, who's also an attending endocrinologist at Richmond University Medical Center. They both have a practice endocrinology on Staten Island. So welcome, a pleasure to see you.
Thank you.
In my practice as a neurologist, going around to the community, I've heard so much recently about polycystic ovarian syndrome, or PCOS. And people who I never thought would have it, people who I didn't know had it, and people ask me questions as a physician, and my knowledge is pretty basic with it, and I thought it would be nice for our audience to hear about it. I'm doing some statistics, reading up about it. About 5 to 10% of women during their reproductive years will have this syndrome. And it can cause irregular menstrual periods, infertility, prone to diabetes, blood sugar elevations. So I want to take the mystery out of like 4 letters. When you talk about PCOS, they see letters. And we talked about the words polycystic ovarian syndrome. But maybe, Philip, if you could start a little bit with us, tell us what it is and how do you get it, and we'll talk about what you do about it.
So at the outset, it's important to distinguish, I think, polycystic ovarian syndrome with ovarian cysts. These are very different things. Many women get very painful cysts with their menstrual cycles on a monthly basis. Sometimes these are treated with birth or oral contraceptives. That's not what we're talking about today. What we're talking about is a syndrome called PCOS, polycystic ovarian syndrome, and this is marked by ovaries that are overproducing testosterone. Testosterone is a hormone that we think of really as a male hormone, and really men are a combination of estrogen and testosterone, and women are a combination of estrogen and testosterone. But we have very different ratios of these two hormones. Men obviously have much more testosterone than women, and women have much more estrogen than men. But the condition we're talking about, PCOS, results when the ovaries produce too much testosterone, and this interacts with the pituitary gland, which is the other topic for tonight, which is the gland in the brain, and this throws off the menstrual cycle. And the menstrual cycle is important not only for reproduction, but it's important for women and their bone health and their cardiovascular health. So this syndrome, this overproduction of testosterone, can affect multiple different processes in a female patient up until the age of menopause.
So Lena, tell us a little bit about who should be taking care of people who were told they may have PCOS. And I know sometimes some facial hair in young women really is one of the clues, irregular menstrual period. Where should they go? Should they go to their gynecologist, their primary care physician, an endocrinologist? How do they decide?
We have talked about multidisciplinary approach with other endocrine diseases. This is also one of the illnesses that is quite complex, and so it requires multidisciplinary approach. These women are usually diagnosed by their gynecologist, whom they see for regular gynecological care or obstetrics issues, and then they see an endocrinologist as well. And Depending on what this polycystic ovarian syndrome causes, they may have to see a counselor, a psychologist, or a psychiatrist. They may have to address the hair issue, meaning unwanted hair on face and thinning of the scalp hair. They may have to seek treatment for that. It's very uncomfortable for a young female to have to remove hair from face frequently, so they may have to see those kinds of treatments. They certainly have to keep up with their primary care doctor, because the polycystic ovarian syndrome in turn puts them at risk for other illnesses such as diabetes and all other unwanted outcomes of that. So it is also a multidisciplinary approach type of illness.
Well, how do you make the diagnosis?
It's a great question. There are three main criteria that we use to make this diagnosis. One is evidence of androgenization, that is too much circulating testosterone. So we can either make that diagnosis on a blood test by literally checking the young woman's testosterone level. That's one criteria. The other thing is actually to look at them on physical exam and to see. Testosterone is something that I always say puts hair where you don't want it and takes away hair where you do. So Dr. Perel and I understand this well. The testosterone has taken hair from us, but we still have hair on our arms and our legs. And so the point is, when a young woman has too much testosterone, a similar thing can happen. You can get hair on the face, you can get hair below the belly button, around the nipple. And actually some women can complain of hair loss on the top of their heads as well. So that's the first criteria. The second criteria is abnormal menstrual cycles. So, people that skip periods or have 2 or 3 periods per year, that's another criteria. And the third criteria is actually when we do an ultrasound for a young woman and we see classic findings of polycystic ovaries on an ultrasound examination. Now, you only need 2 out of 3 of those criteria to make that diagnosis. So can you have polycystic ovaries without the typical imaging evidence of polycystic ovaries? The answer is yes, you certainly can. So those would be the main approaches to the diagnosis. But importantly, we also have to rule out other causes of an abnormal menstrual cycle. And there are many causes for an abnormal menstrual cycle, specifically, which we'll talk about later, pituitary tumors, people that have eating disorders, people that actually have ovarian failure. All of these are important parts of the differential diagnosis in order when we look at and evaluate a patient that has abnormal menstrual periods and the possibility of carrying and having the diagnosis of PCOS.
So Lena, sometimes we say that someone can't be a little bit pregnant. And either you are or you're not. With PCOS, is there a difference in severities? I mean, most diseases we have, some people have high blood pressure, severe hypertension, we call it malignant hypertension, which is huge, 250 on the top number, and some people have a little bit higher, maybe 150, 160. Is there a difference, or do some people have much more in the way of symptoms and much more in the way of problems than others?
Absolutely. So there's a different severity. Some patients really don't even know they have it. They have somewhat regular cycles. They don't pay attention, is it 28 days or 32 days, or is it 28 this month or 35 next month? If they don't have any terrible variations in menstrual periods, if they're not disturbed by a little bit of facial hair they have, they may miss these things, right? Ovarian sonogram is not something that is done routinely by gynecologists. It's done if there is a suspicion for an illness. And so if the patient doesn't complain and sort of decides that slightly irregular periods are acceptable, which they certainly are to most young women, then this even may go undiagnosed, right? Some of these women have no problem getting pregnant, so they wouldn't even know they have PCOS. A couple of extra facial hair, maybe a skipped period here and there. So those are fortunate women who don't have excessive symptoms. And some patients, depending on the levels of these male type hormones such as testosterone, have severe symptoms. They have either complete lack of periods or very infrequent periods. They may have this hair situation that we talked about. They may have mood fluctuations because when periods fluctuate, that's a sign of abnormal hormones, right? Those estrogen and progesterone, testosterone. So when these hormones are not produced in a precisely normal way, that causes mood fluctuations, and that results in sometimes impaired functioning during just their adult lives, right? If they're very anxious one minute and depressed on certain occasions, it may interfere with their family lives and their careers. So it's a spectrum of symptoms, and treatment, of course, makes it better, but some women are certainly not disturbed by their symptoms.
Let's talk about treatment, but how commonly do you see it? Do you think it's happening more often? Because I'm hearing about it more often, so you tell me.
Yeah, I think there's actually a dramatic underdiagnosis of this condition from folks. As Dr. Likina pointed out, there are some patients that are very comfortable not getting their cycle on a consistent basis, and they don't even report this to the gynecologist. There's also been a tendency, in my view, to just think, oh, well, they're just a little bit abnormal, leave them alone. And this is I think is wrong. The reason is the menstrual cycle is not simply about fertility, although that's very important. The menstrual cycle, the exposure to the right amount of estrogen in the body, is critical for a young woman for several reasons. Prevention of cardiovascular disease and achieving the peak bone mass. Young women achieve peak bone mass at age 30. Like everything in life, after age 30, things fall apart, as we can all attest to probably on this, in this stage. But with women, peak bone mass is at 30, and then over time, bones start to deteriorate over the course of a person's life. Now, if a woman goes through life not cycling properly, they don't get the right exposure to estrogen, and they don't make their bones achieve the highest peak bone mass. And what they do is they start off at a lower peak than they otherwise would have based on their underlying genetics. And thus, it increases their risk for developing osteoporosis over the course of our lives.
Bones, thin bones.
Correct.
And risk of fracture later on.
That's correct. And additionally, cardiovascular disease. I think it's no secret that most men die earlier than women. And one of the many reasons why this is the case is because of the lack of exposure we have in our lifetimes to estrogen. And women, on the other hand, get the exposure throughout their reproductive life to the estrogen, and it is part of the reason why they're protected from cardiovascular disease, at least until menopause. And when they don't get that proper exposure to the estrogen over that time of their reproductive life, because of polycystic ovaries, because of irregular menstrual periods, they will likely die earlier, more like a man would die because of the lack of exposure to estrogen. So identification is critical, and then subsequently treatment is critical.
So let's talk about treatment. So maybe and we both could tell us a little bit about treatment.
Yep.
And I want to, as we always talk, and we've always had this wonderful conversation and dialogue between us, is the idea there's always the medical treatment, medicines, and there's the non-medicine treatment. So let's start with it's always better to talk about non-pharmacological or non-medicines.
Yes.
Tell us a little bit about things that people could do.
Okay, so up to about 85% of females with polycystic ovarian syndrome are either obese or overweight. And so the best treatment when they see me for initial consultation, I usually tell them, I'm happy to prescribe medications for you, but the best treatment for your condition is actually weight loss. So at times we focus on diet modification, exercise regimen, medications for weight loss, rather than jumping to something that is for PCOS. Now, when lifestyle modifications fail, or if the patient is not obese or overweight, then the next best treatment recommended would be oral contraceptives, birth control.
But your hormones.
Your hormones, right. Birth control, I usually tell women, is nothing but your estrogen and progesterone, but in the precisely correct amounts. In other words, what your ovaries would have made if they were well, if there was no polycystic polycystic ovarian syndrome present. And so that causes regular menstrual periods. As Dr. Atabek said, it exposes their organs, their heart, their bones to normal amounts of estrogen. The mood fluctuations sometimes resolve. If they have acne, that resolves. And so that is the next best treatment. There are other treatments that we use at times if a patient for some reason chooses against birth control or has a contraindication to birth control. At times we use this drug metformin that sort of helps your own ovaries make better or more precise amounts of estrogen and progesterone.
It's also medicine for blood sugar, isn't it?
That is correct. But as you remember, one of the problems body has in patients with PCOS is insulin resistance. They don't necessarily have to have diabetes, even pre-diabetes. Insulin resistance makes the ovaries' job more difficult, and so by reducing the insulin resistance, that's what metformin does. Ovaries of a young woman sometimes are able to kick in and make beautiful amount of hormones, and they cycle regularly, and they feel better.
Okay, so Phil, let's go over, we talked about infertility with this. Can people with PCOS become pregnant? Can women?
So that's a very important question, and I imagine there's a lot of people in the audience tonight concerned. They're hearing us talk about their ovaries, and they're hearing us talk about testosterone and irregular menstrual cycles. They're concerned, am I going to be able to have children? And the answer is yes. The vast, vast, vast majority of patients can have children. Now, some patients, it's a little bit more difficult to get pregnant, and in those cases, there are approaches to that. The base of all of that is still the diet and exercise modification, low carbohydrate diet, and cardiovascular exercise to help keep the weight down, help keep the testosterone down, and allow the woman to cycle normally. In some instances, we'll use metformin to help people lower the testosterone and help them cycle appropriately. There's another medicine called Clomid, or clomiphene. This is a medicine that we give patients to help the patients ovulate. So if you can help the patient ovulate, of course that is a perfect setup for fertilization and subsequent pregnancy. In some patients where that clomiphene does not work, there are some injections that actually we can give to patients to help them ovulate more effectively. And though many patients like that can get pregnant using those injections. And then finally, if that fails, there are approaches like in vitro fertilization, that in which case you would work with a reproductive endocrinologist in order to achieve that goal. So the biggest question is, does PCOS impair fertility? Does it make it more difficult? Sometimes it can. But we have lots of technology, lots of different approaches, lots of medication that will help women that are suffering with this condition achieve pregnancy, and it will be a very, very, very small sliver of patients that will be infertile. It will be very, very unusual.
That's marvelous. Thank you. We're gonna move on a little bit. Anything else you'd like to talk about PCOS? We covered it. Okay.
Yeah, I think we covered it.
So now we're going to talk about pituitary gland.
Yeah.
And as a neurologist, the pituitary gland is always an interesting gland because we do a lot of imaging studies of the brain.
Yeah.
And when you get a picture of the brain, the pituitary gland, which is not the brain itself, not brain tissue, you don't think through your pituitary gland. You don't move your arm, your legs. You don't see through your pituitary gland. It's in the picture.
Yeah.
And I get pictures of patients' brains, something like a CAT scan or an MRI, very frequently with people with headaches, strokes, multiple sclerosis, Parkinson's, whatever you could think of that I would see in my office. And the pituitary gland's sitting there. And many a time I get a call saying the pituitary gland is enlarged. It's big, there might be something on top of it called an adenoma. And over the years I've sort of tried to become a little bit more expert in pituitary abnormalities and what we do to take care of it. But clearly I love to have my endocrinology colleagues help me figure out what to do. So let's talk about the pituitary gland, and other than it being in the brain, in the head, I'm not sure, it's not really in the brain, it's in the head. Yeah. But being that little gland in the head, what does the pituitary gland actually do? And we'll talk about some of the problems that occur with it. Lena?
So pituitary gland is a master gland. Anything that sits in the head, such as brain, controls everything else. And so pituitary gland controls a lot of other endocrine tissues or endocrine glands that are located throughout the body. Take, for example, thyroid, right? Pituitary releases a hormone that regulates thyroid function. Take, for example, ovaries we just talked about. Pituitary releases two hormones that regulate cycles and ovarian function, ovaries being also glands that make hormones. And so pituitary takes control. Our stress hormone, it controls how that is released, and there's a hormone that pituitary makes to control stress hormones. So it basically is the boss of other glands. And so we'll talk about adenomas a little bit, but any kind of malfunction or any kind of disturbance can disturb, you have to realize, many other functions in many other glands throughout the body. So it really is a very important endocrine organ, the pituitary.
So that's what it does. So it controls the thyroid, it controls your adrenal glands, it controls your ovaries, reproduction, many different things. So what kind of abnormalities do we see? So we think about it, I mean, whether you watch professional wrestling and see a guy like Andre the Giant in the past, but who has gigantism or acromegaly, that's also a pituitary problem. So tell us a little bit about the abnormalities you see in your practice with people who've got problems in the pituitary.
So the most common abnormality we'll see, and this is, I think, what you're seeing, Dr. Perel, on your imaging, is subtle abnormalities of the pituitary gland, many times adenomas or little tumors of the pituitary gland. Now, I use the word tumor, and I know that frightens a lot of people. Tumors don't necessarily need to be cancer. Tumors are either cancer or benign. The vast, vast, vast majority of pituitary tumors are benign tumors. So generally speaking, if your doctor tells you you have an adenoma on the pituitary gland, we're talking about a benign lesion. Now, the question is does that tumor make too much of a hormone, or is it basically just sitting there doing nothing? So in order to understand what's happening, we do a variety of hormonal testing. We do blood testing for looking at the pituitary thyroid axis. We look at blood tests to look at the pituitary ovarian axis. We look at blood tests to look at the growth hormone levels, and we do many times a 24-hour urine collection to look at the stress hormones called cortisol. And each of these, if there's an excess of these hormones from the pituitary gland, you can have all different disease states. The one you talked about with Andre the Giant, acromegaly, that is an excess of growth hormone production from the pituitary gland, usually caused by a tumor. That tumor, when it's hormonally active, needs to be removed. Many times, however, the tumors are not hormonally active, and we have to just follow those patients with imaging.
Interesting enough, as in my field, in your field, the surgeons or the people who take care of it do it from a very interesting approach. And most people think of anything in the head, you have to open up your skull and take it out. Here, as you know, they do what's called a transfemoral approach. They go actually through your mouth and the sinus and pull it out.
Yes.
So thank goodness the surgery has become more without disfigurement, less time, shorter procedures and things like that.
And patients can be discharged pretty quickly from the hospital after a couple of days.
So if someone goes to me, or their internist, and they get an MRI of their brain and they're told they have an adenoma.
Yep.
Should they go see an endocrinologist?
I think most of those patients would wind up in the endocrinology office. I think that they should be. Most primary care doctors, I don't know, I mean, some of them are excellent, but some of them might not be as familiar with the entire workup relative to a pituitary finding. So I think that most of those patients probably should wind up either in an endocrinology office or even a neurology office to complete the workup.
So let's talk, Lena, a little bit other than tumors. So we talked about adenomas, which are growths. The growths can secrete hormones, not secrete hormones. Tell us a little bit more about pituitary problems. Some people will have just elevations of hormones without having the adenoma. They don't have to have surgery for it. Medically, are there ways for you to treat? And it sounds almost like a witch's brew. What could you do to reduce certain hormones? So let's say one of the hormones that is involved is something called prolactin.
Right.
And if you could tell us a little bit what prolactin does, and is there anything we could do to actually knock down the prolactin level without doing surgery?
Right, absolutely. So we actually use medicines hoping not to get to the point where the patient needs surgery, and these medicines, when used appropriately, they work great. So prolactin is something pituitary makes. The only use we humans have of prolactin is when women are lactating, producing milk to feed their babies. Otherwise, prolactin really has no use for our purposes, especially in the male individual. So at times, pituitary just makes a mistake, whether there is an adenoma or not, and just makes more prolactin than ideal. And so patients have symptoms, they're quite uncomfortable, and at times that affects fertility. At times in a male patient, it can affect testosterone by lowering production of testosterone, which makes a patient quite uncomfortable in many different ways: fatigue, loss of muscle mass, loss of bone strength, so to speak, or bone density. So it affects a lot of different other hormones. It may affect thyroid function just by default, because the hormone that regulates thyroid also comes from that same area. And so there are medications that effectively treat that prolactin, in other words, are able to lower it down. Now, if there's an adenoma, a mass, a lump on the pituitary that produces prolactin, you again hope not to intervene with a surgical intervention. So these medications are actually able to affect the size of that mass to reduce it and to avoid surgery or complications. For example, sometimes these masses, they can press on nearby structures. So by reducing the volume of those lumps or masses or adenomas, we're able to avoid a lot of problems.
So we have medicines that actually could turn off the production of prolactin. And that's a
Absolutely.
wonderful thing that we
Yeah.
see. We're going to go ahead just a little bit because we have a couple of minutes left. And you mentioned thyroid a few times. And so many of our people in our audience and people on our staff and people even who are filming us here today have thyroid problems. Tell us in 1 minute approach, too much, too little thyroid. Tell me a little bit about that, Phil.
You want to talk about the thyroid itself, or
Yeah,
do you want to
thyroid
talk about
gland.
the pituitary?
What happens if you have too much thyroid or too little?
So the thyroid gland, you can make too little hormone or too much hormone, and when you the thyroid and the thyroid hormone affects you from head to toe because there are literally receptors from head to toe. So if you have hypothyroidism, you might complain of things like
Or too little
fatigue,
thyroid.
Too little thyroid. So you might complain of fatigue or weight gain or depression, dry skin, hair loss, particular loss of the eyebrows, and these are very uncomfortable for patients. So if we identify a slow thyroid or a hypothyroid patient, it'll be important to give them thyroid hormone.
And so I'll let Lena talk
Yeah.
about hyperthyroid, too much thyroid.
So too much thyroid hormone, again, is a mistake made by the gland. And so patients have, some patients absolutely have no symptoms and are surprised that their levels are abnormal. But some are quite uncomfortable. They may experience, I usually tell patients thyroid hormone is an upper, right? So they may experience anxiety, lack of sleep. In a female patient, they get irregular periods. In male patient, they may have low testosterone, again, with the subsequent symptoms. They may have heart palpitations, which is becoming aware of the heartbeat. We usually are not aware of heartbeat, and that can put you at risk for heart arrhythmias and strokes and heart attacks. You know, that's another mistake, so to speak, of a hormone production, for which we use medicines effectively, and there are the treatments available as
And
well.
I think at the time in my career, what's been so remarkable about endocrinology or hormone medicine is the way all these hormones have been synthesized. When I was growing up, they didn't have all these things. Even the generation before myself where thyroid replacement was something really not known or heard of. And then they came up with thyroid replacement, and then they were able to, as Lena mentioned, give medicine to turn off certain hormones, turn on certain hormones, reproduce hormones. And we talked about the pituitary for a while now. There's actually a syndrome where you might not, your pituitary can turn off, called panhypopituitarism.
Yeah.
Just means that your pituitary doesn't work. And people could survive. In the old days, people died from that. Maybe you could just tell us a little bit about how, just in a few seconds that we
Yeah.
have left,
Yep.
about what it's like because of all the new medicines that are out there and the new testing for hormones and be able to synthesize it.
I mean, so many of these medicines are really, truly life-sustaining. I mean, even type 1 diabetes, people used to develop hyperglycemia as children, and they would just die because of the lack of insulin. So these hormones, and the other case of the adrenal hormones, the cortisol, people that have Addison's disease or deficiency from their pituitary gland of ACTH, these drugs, the steroids, literally keep those people alive. Without the medicines, they will be dead in several days. So the fact that we're able to do that is truly remarkable.
So we could replace a lot of them, and that's where
Yes.
I know so many of my friends and colleagues have gone into endocrinology because there's so much more that you could do now than generations before. There was a lot of thinking about things before. Now we're able really to treat and be very interventional with it, and it's become such a cutting-edge process. So I want to say thank you all for coming. We learned a lot today, learned all the hormones that we have, and hopefully keeping our hormones in balance will be good for us all.
Yes. Thank you.
Yeah.